Well, it's a very pleasure and honor to present to this audience. I must say that I was sitting there and I couldn't help remembering a day, probably less than 20 years ago. It's not ancient history. When I attended a meeting, it was some other lung organization, which we'll go and name, and they were trying to figure out strategic priorities for the next year that where they're going to work on. And I was, let's work on asthma. Work on asthma. Air pollution. All right, air pollution. Yeah, that's good. What's the third one we can work on? Yeah, nobody could figure it out. And how about COPD? No, we don't want to work on COPD. Those people, they deserve what they got. There's nothing we can do for them. And why would we want to waste our time working on COPD? It's really remarkable how things have changed and gotten better. I now travel to all kinds of nice places like USC. As far as USC, talking about COPD, and it's been a very nice trip, because after all, there is stuff we can do now, and I'm going to talk about advances in COPD therapy, and people like Brian Type and the other speakers have contributed to this a lot. The real reason why we can't very well ignore COPD is because it's just a major healthcare problem. We've seen the numbers: 24 million people afflicted, half of them diagnosed, and the solution to not having enough spirometry is to do more spirometry. More spirometry. As of this year, it's advanced. We're now the third leading cause of death, nosing out stroke deaths for the first time. Death rates are rising. Mortality rates are rising among women. Now, this will reverse. This will reverse, especially in California, where we're doing such a wonderful job, a public effort to have smoking cessation. What is it, 12% now of adult smokers now? Really a great victory. And seriously, when I go around the country and other countries, I can really brag about California. I tell them we do a lot of things that are crazy here, but this is one thing we do really well. Healthcare costs are huge. The key myths of COPD, and this is not news to this audience, is that it's a disease of self-abuse. No, it's really a disease of addiction. And it's a tough addiction, and most people become addicted when they're 13 or 14, when you're really stupid anyway. You do a lot of stupid things. And it's a very tough thing to kick. And people who can manage to stop smoking deserve our praise and support, and those who can't at least deserve our sympathy. It's irreversible? No, it's not irreversible. It's a reversible disease. There are lots of things we can do about it. And here's my sort of a menu of things that are sort of being worked on by various people. Modern treatment for COPD, advances in COPD. First of all, bronchodilators are really our mainstay of therapy. Long-acting bronchodilators have revolutionized COPD therapy. In the last 10, 15 years, we've gotten drugs that are really quite good. Long-acting beta agonists, called LABAs, salmeterol, formoterol, given twice a day. Long-acting anticholinergics, tiotropium, Spiriva, once a day. These are really good drugs. They do a lot of good things. They give you sustained bronchodilation, 12 or 24 hours. They reduce dyspnea, shortness of breath by well-validated measures. They increase exercise tolerance. We do this in our laboratory. We know the mechanisms. Brian even showed it, was kind enough to show a slide showing decreased hyperinflation as a mechanism. Better quality of life by well-validated measures. And fewer exacerbations of COPD. Actually, a surprise that these long-acting bronchodilators do this. And I'll present some data on that a little bit later. What's next? Well, there are some new bronchodilators in the works. The so-called ultra-LABAs. Sounds pretty Buck Rogerish. Long-acting beta agonists now to be once a day instead of twice a day. There's a drug that's actually been approved. Will be in the market very soon. And then combination once-a-day therapy, combining once-a-day anticholinergic and beta agonist. Next 2 or 3 years, we'll have those in our hands and be able to use them. Here's a slide of the once-a-day beta agonist, Indicaterol. Indicaterol, new name you'll need to know. And essentially it shows the FEV1, this measure of airflow obstruction. It increases when you give the drug, and 24 hours later, it's still hanging around above baseline. And these different curves are different doses of Indicaterol compared to the usual dose of tiotropium. So the point is, if you like tiotropium and the way it sort of bronchodilates, you're going to like this drug, which has the same sort of time course of action. Even more importantly, we are having combination drugs, and these drugs work very nicely. If you dose a patient with tiotropium or formoterol, a beta agonist, twice daily beta agonist, and a once daily anticholinergic, you see you get an FEV1 increase, appreciable. But if you give them both together, here's what you get. The combination, 1 + 1 = 2. These are different mechanism bronchodilators, so if one's going to work, the other one's going to work. Well, you add them together and they give you additive benefits. This magnitude of bronchodilation, 10 or 15 years ago, we would have said, oh, well, this must be an asthmatic patient because only asthmatic patients have improvements in lung function with bronchodilators. No, COPD patients do very nicely with our new drugs. It turns out that whole bunches of companies, this is a big market, whole bunches of companies. My friend Jeannie Paris back there, GSK is developing a once daily combination, so is Boehringer Ingelheim, so is Novartis. Who's going to get to the market first and argue and have funny TV commercials? This will happen. This will be there. A couple of years, just wait and see. These will be nice drugs. New classes of bronchodilators. Well, there's one molecule I thought was sort of cool. It has both a beta agonist and anticholinergic in the same molecule. I guess that's nice. And then there are new mechanism bronchodilators on the drawing boards that will come along. None of them very far along, but glimmers in our eye. Anti-inflammatories. Well, you know, for, again, the last 10 years or so, we focused on COPD being a disease of inflammation. Even the emphysemic patients have inflammation of the lungs. We figured if we can quiet that down some, we'll have done a good thing. But you say, well, we have an anti-inflammatory therapy. We have inhaled corticosteroids. And in fact, we do. And they're good drugs. But the COPD inflammation is predominantly a neutrophilic inflammation, which is not particularly sensitive to steroids. Thank you, inhaled steroids. A little Rick Perry moment there. And inhaled steroids, while they are effective, still haven't shown some of the benefits we would hope for. Things like slowing progression of COPD and improving mortality. We've been pretty clearly shown that they don't do that. So there's a thought we need better anti-inflammatories. And in fact, there's new approaches that are being worked on actively. One is to try to reverse the resistance of the COPD patient to corticosteroids so they work better. And then there's a move to have novel anti-inflammatories. This is a slide from Peter Barnes, who's a guy from London who publishes almost every year. He'll publish what's new in COPD. And he's a very authoritative guy. He's always right. Just ask him. And here's his scheme for the different kinds of things you could approach in COPD. And over here is a list of anti-inflammatory treatments, and it's like an alphabet soup of different names, PDE4, IKK2, PD, P38, all kinds of stuff that Peter Barnes says are good approaches. And in fact, here's a chart that he made of what's being tried and what's been not. All these are different anti-inflammatory. The inflammatory cascade is fantastically complex, well beyond my ability to figure it out. And here he says, well, here's a whole bunch of things, and sometimes, development stopped. Well, what happened? Anti-TNF alpha was going to be a really good target, but it didn't work. They tried it, it didn't work. This is a very difficult field with companies spending a lot of money on mechanisms that may or may not work out. But we're hoping to come out the other end with a couple of drugs. And in fact, where is it? This one, PDE4 inhibitors, we have a new drug out, and I'll tell you about that in a little while. Reducing exacerbations is probably the victory march of the last few years. About 10 years ago, we sat down and said, those were thinking about COPDs, wouldn't it be nice to cure it? I said, well, we're not smart enough. We're not smart enough. We can't figure out a way of curing the disease. But, geez, here's exacerbations. That's a really good target, and we have to be very smart to figure out ways of decreasing the frequency of exacerbations. And in fact, there's a good reason to work on these. It's a common cause of mortality. Lung function declines faster in people who get these COPD illnesses. We know that people who have exacerbations before are the ones most likely to get exacerbations again. And COPD hospitalizations for exacerbations are a major driver of medical costs, and we certainly want to deal with that. Here's a figure that sort of addresses that. This is a the COPD dollar, how much we spend, $29.5 billion. And in the Obama world, that's not it's only billion, it's not trillion. But $29.5 billion, and here's the pie. And you notice here that 68.5% of it is spent on hospital admissions. Not all of it is for exacerbations, but a lot of it is. You think, well, the drugs are really expensive. Drugs are only 8%. The big thing is COPD hospitalizations. So again, if we can reduce exacerbations, we'll reduce hospitalizations, and we'll all feel good. And Brian doesn't have to be called in the middle of the night to take care of his patients. And frankly, in short order, we came up with a nice list of things that really are documented to reduce exacerbations. Flu shots and pneumovax shots are the no-brainers. Those really work, well documented, they're cheap, they're easy, and every COPD patient should have them. Inhaled steroids reduce exacerbations. So do long-acting beta agonists, and that's a good study of that was published in New England Journal of Medicine. It means it must be right. Can't be wrong in New England Journal. This is the TORCH trial done by GlaxoSmithKline of their drug Advair, thank you. Salmeterol plus fluticasone. It's a senior moment. That's fine. And what they did is they exposed about 6,000 people over a 3-year period to components of the drug or the combination. And they found that the number of exacerbations, salmeterol alone, the beta agonist alone, 15% reduction in exacerbations. You give an inhaled steroid alone, 18% reduction. And if you give them both together, which is the Advair, 25% reduction. Get sick 25% less often just by taking a spritzer twice a day. That's a pretty good deal. Long-acting anticholinergic, same sort of story. This is, again, New England Journal of Medicine paper, the UPLIFT trial, tiotropium, showing that, in fact, if you give tiotropium and look at the probability of exacerbations over a 4-year period, this time in 6,000 people, hazard ratio, that means 14% fewer exacerbations just by taking a spritzer of tiotropium once a day. A good deal. Other things, long-term oxygen therapy. People who need oxygen and take it get sick less often. Pulmonary rehabilitation makes you sick less often. And I was going to sneak a change in the slide. Instead of collaborative self-management, I was going to say Dr. Type's approach. Because that's exactly what Dr. Type's doing, working with your patients so they know exacerbations, they get treated early before they get sick and end up in the hospital. Absolutely the epitome of that approach. New approaches. Well, as I said, there's a new drug, there's a new kid in the block, newly minted, FDA-approved roflumilast, easier name to say, Dalaresp. It's a once-a-day phosphodiesterase 4 inhibitor, the first new mechanism drug we've had in a long time, and that's a good thing to have. It's specifically indicated for people with COPD who have chronic bronchitis and have severe disease and have had exacerbations. That's a subset of COPD, but nonetheless, it decreases exacerbations by here it is. Decreases exacerbations by 17%. So this is take a pill once in the morning, and you'll get sick 17% fewer times if you're in that category. Second new approach is chronic antibiotics. Now, there's probably no infectious disease people in the audience who hate this concept of giving people antibiotics all the time, and I don't disagree with them. But in any case, we did a study of azithromycin, macrolide antibiotic, and again, it got published in New England Journal of Medicine, this time with my name in it. Where we took 1,142 people and gave them, who had had exacerbations in the past, and gave them either a dose of azithromycin every day for a year, or placebo for a year, on top of everything else they were taking, and in fact found that the azithromycin group got sick a lot less often, 27% fewer exacerbations. This is a really good effect, especially when it's on top of all the other good medicines they were taking. So this is not that everybody should be on antibiotics with COPD, but it's that the people who are having a lot of trouble with exacerbations, having a hard time keeping out of the hospital, this sort of gives you a lead to treat them with chronic antibiotic therapy. I think it's a nice study. New drug, new concept, statins. We all know that I took my Lipitor last night, and because I don't want to get a heart attack, and it's working. So far. But the idea is that it might decrease exacerbations. It's an anti-inflammatory, so it might work that way. Some studies suggest it might, but this is the definitive trial, we hope. This is by the COPD Clinical Research Network, NIH, money, your tax dollars in action. 1,132 people being randomized to receive simvastatin at a moderate dose, one of the statins, versus placebo. This is in COPD patients who don't have cholesterol problems, because if you had cholesterol problems, you'd have to give it to them. You couldn't withhold it. But these are people who have indications other than cholesterol problems for statins. And we're following exacerbation frequencies, and we have 449 people recruited out of 1,132. And this is, if anybody has the ability to send us people who might be interested in research projects, see a couple of my friends out in the audience, we would love to have people referred for this really nice study. I feel bad about talking about oxygen therapy because the world's expert is sitting in the front row there. I call it the perfect drug. It's got really marvelous physiologic effects of increasing oxygen supply to the tissues, vasodilating the pulmonary circulation, and inhibiting the carotid body, which results in good things like reduced dyspnea, increased exercise tolerance, and by a lot, even in people who don't qualify for oxygen, it improves exercise tolerance a lot. And of course, it improves survival in people who have low oxygen levels, as our sainted Dr. Tom Petty showed us. There are some good news and bad news in oxygen therapy these days. The good news is new technology. Again, Dr. Type has introduced most of the new technology one way or the other over the years. The new stuff is that we can now deliver oxygen without a truck. You know, the most expensive thing about oxygen therapy is the truck that brings it to your house. So we can get by with not having to drive the oxygen out there, and after all, the oxygen's all around us. Why can't we use that rather than having the truck? So home fill oxygen cylinders, devices that fill portable oxygen cylinders, devices that fill liquid oxygen tanks, and devices that just with electricity process air and take directly it out of the air as you go, are all nice devices. And being an engineer that way back, I just love this stuff. The bad news is actually sort of manifold. A lot more people in the United States use oxygen per capita than any other country. And that's not because we're good doctors, because we don't select our patients very well, and we don't rescreen them once we've given them their oxygen. That's a big problem, because it's a very expensive therapy the way we practice it, because we give it to a lot of people. Medicare is getting tired of that. They pay for most oxygen therapy, and they're trying to find ways of saving money. And they're saving money in the worst way, because a lot of it is actually harming the patients, I believe. And the other thing is that many patients who receive oxygen don't meet the criteria. They may have at one time, but they don't anymore. And we need to really rescreen them to make sure their needs are being met. There's a big oxygen trial underway, another one where I could use anybody's help that's got the access to people who might qualify. We're trying to refine oxygen prescribing practice. As I say, we give it to people. I think we're being appropriate by sort of straining the indications, because we're not really sure. The question is, are there benefits of oxygen therapy in people with isolated, who only have low oxygen levels when they walk around? Are there benefits of oxygen therapy for people whose oxygen levels are not very low, but only moderately low? And the answer is we don't know, because we never really looked. We've never really done the studies. So this study hypothesizes that we're going to take people whose oxygen saturation is sort of in a middle zone, not bad enough to receive it today, or who have very low oxygen levels when they exercise, and randomize them to receive oxygen or no oxygen in a sense, and then see who dies first. So who look at mortality and hospitalization as a result. And this is sort of technically how we're going to give the oxygen. But we're trying to get like 1,200 people. We've got about 400 so far in about 2 years. It's a very slow slog. You see the centers around the country that do this. In fact, there's 2 sub-centers. One is at Dr. Type's place at City of Hope, another one at Loma Linda VA, who are sort of sub-sites who are formerly processing patients. This is a very difficult study. The problems are that we need, as I said, 1,134 people to be followed between 1 and 4 years. It's a big deal. There is a prejudice in the community that people who, especially who have low oxygen levels when they exercise, when they walk around, should get oxygen therapy, so people are reluctant to refer. And as I said, we've only got 390 people out of 1,134 in a little over 2 years. So we need help. Anybody has any facilities, we'd love to talk to you. Pulmonary rehabilitation is my favorite thing to talk about, it has substantial benefits. Improves exercise tolerance, reduces dyspnea, improves quality of life measures, and it does it, in fact, better than any other COPD therapy we have. So it's quite effective. It's a multimodal therapy, as you know. Exercise training is probably its core. That's only important at that point, but it's core. And we've worked on ways over the years to try to explain why it works so well. Dr. Type expressed some of the issues of hyperinflation reduction, breathing pattern reduction. We published this thing in New England Journal, must be right, a couple of years ago, showing that it works on a number of features, desensitizing to dyspnea, decreasing anxiety and depression, reducing dynamic hyperinflation, improving the function of the muscles, all will tend to improve the ability to exercise. When people exercise more, they do better. We've been trying to find ways of making rehabilitation more effective, including giving good bronchodilators during rehabilitation. That's sort of a no-brainer. Supplemental oxygen, even for those people who don't need it by Medicare criteria. I'll show you some data on anabolic steroids. Interval training, Dr. Hester Vandervaart, sitting over there, a pulmonary physician from Holland, is with us for a year to try to do a study where we're doing a special kind of interval training where you exercise at a very high level for a little while, and then a lower level and a higher level, low level. Show that's more effective, at least we hope so. And a non-invasive ventilation, I always thought this was an interesting thing, but it wasn't practical. But here we have a device. This is a cool device to let you do, essentially have a ventilator to walk around with. This guy has what looks like an oxygen tank cannula in there, but no, it's a sort of a semi-occlusive thing in his nose, and every time he takes a breath in, it sort of gives him a little boost. Helps unload his muscles, makes it easier for him to breathe in. And the device is that's a ventilator. It weighs a pound. It wears it on his waist. It can weigh a pound because it actually uses the oxygen tank that he's wearing because he needs oxygen as the motive push for the thing. So it's a really cool device. And we're trying it out in our lab and looking at the physiologic aspects of that to see if it really does help people with COPD. I have to start. I've been giving this talk for a while, but you have to start talking about therapies that are only good for a subset of COPD patients. Now, it's only a subset, who cares? Well, it turns out that if you have a very large number of people and something works for a fraction of them, still that's a large number. So since COPD is such a prevalent disease, even a subset of them is something that's worth working on. And these therapies, including anabolic drugs for people whose muscles don't work very well, the muscles are dysfunctional. I'm talking about the muscles you walk around on, generally don't work very well, partially because people don't do very much. They get disuse atrophy. The drugs we have to work with so far are only those that make muscles bigger. They make them stronger in essence. They don't make them more efficient as in runners. They make it bigger as in weightlifters. Well, it's important. If you stand up and you don't want to fall down, your muscles better be strong. So that's a good thing too. Growth hormone is one of the molecules. There's a new drug called the growth hormone releasing factor agonist that works directly on the brain. We're trying that out in a trial right now. I'll show you data on testosterone, and then there's testosterone analogs called the selective androgen receptor modulators, called SARMs, that have no side effects, which are sort of nice, that we're starting to work on. This is a study that we did several years ago and published, not in New England Journal of Medicine, so it can be wrong, might be wrong, showing that if you give testosterone to a group of COPD patients, their muscles get bigger, and if you give it to them in conjunction with a strength training program, their muscles get even bigger than that. This is 3 or 4 kilograms of muscle, which is actually pretty appreciable in 10 weeks. And in fact, if you measure strength, they get stronger. So testosterone alone, strength training alone, and the combination. So we can make people somewhat stronger with these drugs. Whether this is something should be used routinely is not quite clear yet. Cachexia is becoming a special interest of mine. It's not very many people have it, it turns out, but doctors diagnose this all the time, and I think it's really profound. When you've been taking care of a patient for a year, they have COPD, and it's pretty severe, and they come in your office one day and they look like hell. They look like they're wasting away. You say, well, what happened to you? Oh, I've been losing weight. Don't know why. Well, that's cachexia. And it's a very difficult problem because there's really nothing we have that works. Telling them to eat more isn't the answer. They're not starving. Their body is in a catabolic state. They lose weight involuntarily. They lose both muscle and fat. And inflammation may play a role. We're not really sure. No established therapy. We tried a trial, and this is a small study that was funded by my friends at PERF, Pulmonary Education Research Foundation. That's Mary Burns, for those who revere her. Trying a combination of an appetite stimulant called megestrol acetate, or Megase, in combination with testosterone that we know something about. And we use this in men and women. We thought that the additive benefits might be reasonable. We had trouble finding these people, and when we found them, they tended to drop out. These are people who are pretty ill and have trouble coming in to do the studies. That's a problem. But we managed to accrue 9 people, 5 women, 4 men. Notice that their lung disease is pretty severe, and their body weight is low, but their main criteria for selection was these people who had at least 10 pounds of involuntary weight loss in the last year. So these are people who had what I would think is cachexia. Now, we had 9 people, and it turned out that 4 of them didn't finish because they got sick. Well, that's what happens when you deal with people who are sort of ill. But on the other hand, what we did see was that they gained weight. These are people who had been losing weight, and there's over the 12 weeks of the study, you can see that everybody's sort of bobbling up here. And by 3, 4, even 6 kilograms of body weight, which is actually pretty impressive. Some of them you can see didn't finish the study. Here's one. There's the last point there. That means they dropped out at this point. This person dropped out here. But everybody was on a trend upward. We felt good about that. If we sort of did what's called an intent to treat analysis, we came up with the idea that on average they gained about 3 kilograms. So about 8 pounds. That's not bad for people who were losing weight. And for those who finished, we were able to do body composition measurements to show that they had gained both fat and muscle mass, lean mass, and total weight as well. So we think this is encouraging, but it's much too early to think this is a cure. Although, since there's nothing else, maybe this will have some impact. Lung volume reduction in Los Angeles, we know a lot about this because there's some the NET trial, which was the National Emphysema Treatment Trial, was conducted at a site in Los Angeles. The idea is if you have a lung that's not doing very well, and the worst part of it is up top mainly, you cut out that stuff that's working badly, the rest of the lung can sort of expand out and the patient does better. This trial was actually a very, very well done trial. However, not many people are getting this therapy these days, just not very well used. There's an attempt now to find a way of non-surgically doing this lung volume reduction through the bronchoscope, putting valves in that essentially let air out, but won't let air in, so tend to collapse bad portions of the lung. This is only being moderately successful. And there's a couple of other approaches as well, bronchoscopic therapy. But again, it's a small fraction of patients with severe emphysema. And finally, pulmonary vasodilators. We have a good group of pulmonary vasodilators that have been invented for patients with what's called primary pulmonary hypertension, high pressures in the pulmonary circulation. And they're actually effective, but there are more, even though pulmonary hypertension, severe pulmonary hypertension is present only in a small fraction of COPD patients, it still makes up a lot bigger group than all of the primary pulmonary hypertension patients in the world. So some of the companies are now taking these drugs and trying to do clinical trials to see if they'll be effective in COPD, and those trials are just forming up. Genetically based treatments, everything's in your genes, of course. This is the study called COPD Gene. My favorite study that I participated in. And the question is, some of you will know the answer to this and some may not, but if you take 100 people, if everybody in this room had smoked heavily all their lives, what fraction of you would have COPD? And You know, you ask that to some people, they say, well, 100%, 99%. Everybody will have COPD. Cigarette smoke is such a nasty thing to do to the lungs. Whereas the answer is only about 25% of people do get COPD. So the question is not why people get COPD, it's why they don't get COPD. And what we're trying to do is to answer that. The probable answer is that your genes, it's in your genes. Some people are prone to get it and some people are not. If you don't smoke, you're not going to get it. But if you do smoke, you may or may not get it based on your genes. And so a study was formed, 2007, your tax dollars, to fund this study aimed at determining what essentially is the root cause of COPD, why some people get it and why some people don't. The study strategy was to recruit 10,500 people. Now that sounds like an impossible task, and we actually thought it was. We put the grant in and said, well, we're going to do 10,500 people. Ha ha ha, snicker, snicker. But we actually did it in about 2 years ahead of time. It was a great study. We recruited 750 people at Harvard UCLA. I was really pretty remarkable. I was amazed at it. Again, the strategy was to have half these people everybody's a smoker, half of them have COPD, half of them don't have COPD, characterize these people, including high-resolution CT scans, and then perform what's called a whole genome analysis. Essentially, you take their patient's white cells that have the DNA in them, and you ship it over to Harvard, to get educated, I guess, where they have very sophisticated ways of doing genetic analysis, and essentially they can analyze literally 1 million different genetic characteristics and catalog those and try to determine consistent differences between the groups that do and don't have COPD. So, and then as I said, the CT scans are being very helpful in dividing the COPD patients into those who have airways disease versus those who have the emphysema, sort of parenchymal disease. And the genetic results are just coming out. Now, in fact, I go to Boston tomorrow morning for a 3-day meeting of this group where we're going to see a lot of the genetic analyses, trying to find candidate genes. And the strategy is to find COPD subtypes, find useful things to characterize the disease, find things that determine how fast the disease is going to progress, find these genes that seem to be different between those who do and don't, find out what they do, and then perhaps to find therapies so we can identify novel therapies, new things we didn't think about based on these genetic differences. Wish us luck. Finally, potential cures. That must be the next half hour of my talk, right? Well, it turns out it's not. Potential cures. So here's an interesting one. Stem cell infusions. Everybody's doing stem cells. See about heart stem cells are really productive. Well, we did a trial of stem cells where we gave COPD patients 4 infusions of stem cells and thought their lungs would get better, and they didn't. The good news is we didn't hurt anybody. The bad news is it didn't seem to help. Second one was an alveolar growth factor. We thought we could grow alveoli. It worked in rats. Didn't seem to work in people. So the answer is we have to keep on trying. We will keep on trying for potential cures. And I think I've finished my tour. I hope that this was somewhat helpful.